question. Yes. Oh, have I given you? No. Yes, sorry. Yes.
Okay, has the timer started?
Time has started. You can read the question. You have 30
Okay.
seconds left. You can read and formulate. Bell will go. Yes. Kindly give special emphasis on explaining and speaking out loudly, clearly,
Okay.
in a
Okay.
loud and clear voice. Just 1 second left. Wait. Right. If you have read and understood, kindly begin your examination.
Okay, so I'll walk to the room. I'll wash my hand.
Yes.
So I'll introduce myself. Then I will take permission from the patient, and I'll tell the patient what I'll do. Like, I'm Dr. Sunday,
You'll
candidate.
confirm the identification of patient,
Yeah,
and then you'll
of
take the
course.
permission. Yes.
Yes.
All right.
So then I will explain the procedure.
Yes.
Then I will take consent. Then I will ask the patient, are you in pain currently? Then I will also tell the patient the exposure. So we should be on the short, maybe up above the knee. So I need to be expose the knee up to like the hip. So, but undergarment is fine. Then I will tell the patient that I'll start by watching the patient walk. So I will tell the patient to walk across the room.
Yes.
So I will check for the gait.
What would you consider?
So in this case,
before you'll ask the patient to walk? Yes.
Pain.
Yes.
If the patient is in pain. So
if patient
is in severe
yes.
pain,
Yes.
Yeah, if patient is in severe pain, then I can offer to give a painkiller and skip the walking part. But if the patient is in mild pain or the patient can walk, I will ask the patient to walk, but I will assure them that I'm going to keep them safe by standing beside them at all times. So I will tell them to walk across, first walk, then walk along one straight line, then walk tiptoe and walk on the heel. So then, of course, in this case, I'm expecting to see something like antalgic gait. So then I will, after that, the ask patient to lie down on the couch. So then I will go to
after making patient walk or observing the gait, what else are you going to observe?
So I need to observe. I need to inspect the joint, both sides. So whether they are symmetrical, whether there's any swelling, whether there's any pathological shape like knee locking, or maybe that valgus or varum.
If there are any scars, any wasting
any
muscles,
scar,
yes, good.
So
next.
any color change. Then after that, I will proceed to palpation. So palpation now, I will palpate the temperature with the dorsal part of my hand on both this thing to check for temperature differences. Then after that, then I will also palpate for effusion. So
how would you begin your palpation? Patient has in both knees, but more on right knee. So how would you begin?
Yeah. So first, I will also begin palpation with the LD knee, then go to the more severe knee. So I will go from the normal to the. So then I will palpate the temperature. Then I will feel for effusion. Then by just tapping on the knee. Then after that, I will also do the special tap test whereby effusion for micro effusion swipe test, whereby I swipe from the down and from the up to feel for micro effusion. Then at the same time, I will now check for quadriceps muscle, the diameter to check for quadriceps muscle wasting for both. Then after that, then I will palpate all the joints. I'll palpate quadriceps tendon, and the patella tendon. I'll palpate for any tenderness. Then on the middle part of the joint, lateral part of the joint, I will also palpate the posterior part of the joint and palpate the popliteal fossa, and also feel the pulse to check for any swelling in the popliteal fossa also. Then after that, then I will now proceed to movement. So for movement, I will first start with the active movement.
Very good.
So first ask the patient to extend the knee, then also flex the knee. So I will check for limitation and presence of pain. So why all this time I'm going to show empathy to patient if there's any pain, and probably offer analgesia if there's severe pain. And in severe pain, I will probably take gentle proceed gently and cautiously with the patient. Then after that, I will move to passive movement, whereby I will move the patient's knee myself, with extension and flexion. Then I will now move to special tests. First, I would like to do anterior draw test and procedural draw test to check for ACL and a PCL. So I will start with the elderly knee, like I said, then the pathological knee. I'll be very cautious. So if there's any stiffness or any pain, I will consider I will not proceed. But if there's no pain, then I will do it. Then I also do Lachman test.
Yes. How would you do that?
So I will flex the knee joint about 30 degrees. I will use my hand or my knee to support the knee. So I will just use my other hand to hold the tibia, then do a slight traction, while I use my other hand to fix
How
the femur.
How much flexion would you do of the knee?
Like 30 degrees.
Yes, 20 to 30, yes, approximately.
So after that, then I will now apply do another test for Fagum and the Varum stress test, whereby, of course, I will flex the knee by 30 degrees. Then I will try to flex bend the knee, maybe to outside or inside, to check for the medial or lateral collateral ligament stress test. Then I will do that for both knee. After that, then I will also do McMurray test, whereby I will flex the knee. Then I will now rotate or external rotate to internal rotate the leg, whereby I now from a flexion I will now extend the knee. So I'm waiting for any presence of pain or the sound of click or feeling of crepitus in the knee that may show maybe meniscus injury or injury of the knee, whether medial or lateral, depending on whether it's for lateral internal rotation and for medial external rotation. So I will do that also. Then after doing that, then my time is off.
Yes.
So I will thank the patient.
Yes.
Then
wash your hand, thank the patient, and please present your case. Yes.
So I would like to complete my examination by performing, first of all, complete the joint of below, that's the ankle joint and the hip joint.
Yes.
And complete the neurovascular examination of the lower limb.
Very good.
Then I just examine the patient, a 55-year-old lady, so who complain of both knee pain, but more on the right. Yes. So on inspection, or during walking, the patient has antalgic gait. Yes. So mostly on the right. Then on inspection, there's no obvious abdominal swelling. So, but there's no scar, but the knee is partially deformed. So mostly on the right. Then on the palpation, there is presence of a knee effusion, mostly on the right. So that then presence of crepitus also.
Yes.
And the patient has a negative draw test. Then the Lachman test also is negative.
Yes. And very good. So what are your differential diagnosis for this patient?
Okay. So for this patient, the most probable one will be osteoarthritis.
Yes.
Due to the age and the symptoms, but I would also like to consider other possibilities like traumatic case like ACL injury, or PCL injury, or medial or lateral meniscus injury.
Good. So how would you manage this patient? What investigations would you do or ask for?
So so since I'm thinking of osteoarthritis plus other chronic pathology of knee, so first I will start with X-ray of the knee, so which AP view and the lateral view.
Yes.
Then I would also like to do MRI of the knee to check the integrity of the ligament and the bursa. Then I will now, of course, on X-ray, I should see some sign of osteoarthritis on X-ray, so which are mainly the narrowing joint space, subchondral sclerosis, cyst formation, and the osteophyte, increased osteophyte. So if I see it, then I can confirm my diagnosis. Then I would like to take aspirate the content, so for culture sensitivity and for crystal, to exclude
can you please tell me how, if you think it's osteoarthritis of the knee joint, how would you go ahead and manage this patient?
So for my management, first, I will start with a conservative management.
Very good.
So first of all, if the patient is overweight, I will encourage a weight loss. Then I will also encourage some specific exercise and physiotherapy.
Yes.
Then I will start the medication with the NSAID for pain management. So start with according to WHO anesthetic ladder with paracetamol and NSAID.
Very good.
Then also, if that does not work, then I can proceed to injection of steroid.
Very good.
And if all this fails to work, then I cannot consider surgery.
Very good. Excellent. Excellent. Okay. Right. 5 seconds left, but within time. Right. Yes. Very good. So it was totally a surprise station for you. And yes, anyone else would want to give feedback to Dr. Sunday? Dr. Suman Kumar, is he here? Or Dr. Abhishek? Maybe Dr. Ishfaq? Anyone?
Yes, ma'am. He has most important thing is he has done it on time.
Yes.
And he did all the relevant things needed to do. It was
Yes.
excellent, I must say.
It was excellent. He covered
Yes, ma'am.
everything and within time. Yes, me
Yes,
too.
ma'am.
I'm happy. Very good. Thank
Yes.
you.
Thank you.
Good. Started the station and here is the question. Right. If you have read and understood, kindly begin your history taking.
Yes, ma'am. I will enter the room. Hello. Good morning.
Hello.
My name is Dr. Ishfaq. I'm one of the doctors working here. May I confirm your name, age, please?
I'm Jane. I'm 66 years.
Jane, nice to meet you today. Today I have been asked to ask you a few questions regarding your condition. It is appropriate time for you. Should I proceed?
Yes, of course, doctor.
Okay, great. Thank you very much. So can you please tell me how can I help you today?
Actually, doctor, I've come to you today because of this swelling in front of my neck.
Okay.
So this swelling has been there for quite some time now, and I've learned to live with it for it's been there for around 10 years or so. But
Right.
the problem is, since the last 2 months, it's been increasing, and I feel it's grown bigger in size. And it is also, it is getting difficult for me to swallow anything. Even right now, I can't
Right.
swallow any solid food. So I'm really anxious about this. And the other thing is, my voice hasn't. I feel like I've changed my voice or some. There's a change in my voice, and it's
Okay.
become more difficult for me to speak. Then
Right.
there are other problems, like I feel like I've lost a lot of weight in just in a short period of time. So, and I feel very
Right.
anxious and I'm disturbed all the time and not in a good mood most of the time. Normally I'm not so
Right.
all this thing is just troubling me, so I've come to you today.
Right. Firstly, Jane, I'm really sorry to hear that you have been suffering from this problem. It's impacting your life. Can you please tell me more about your condition? Like you said me, it was you observed this swelling 10 years back. Do you think it was all of a sudden, or did it, increased in size gradually?
I think since the last 2 months it increased all of a sudden, but it's
All of
been
a
maybe
sudden.
increasing. I did not notice.
Okay, you do not notice. Have you been experiencing any difficulty with your breathing or your swallowing?
Sometimes, yes.
Sometimes. Right. Okay. So, have you been experienced any fevers recently?
Fever? No, not really.
Mm-hmm.
Sometimes I feel feverish, but not so.
Okay. No, not so. Okay. Okay. Have been experiencing any, you have been, you observe your heartbeats, you feel your heartbeats, anything, something like that?
No, doctor.
Nothing like that. How has been your water works and your bowel movements?
They are fine. Not a
Okay,
problem in
great.
there.
Okay, have you experienced any tremors in your hands recently?
Uh, yes, sometimes I do notice that my fingers tremble.
Okay, right. So, are you feeling overly tired over the day? Are you're not feeling the same energetic as you were feeling before?
Yes, I do that sometimes, yes.
You do that sometimes. Okay, right. Is the swelling associated with pain or not?
Sometimes there is pain, but most of
Mm-hmm.
the times it's just there in front, a big thing. Yeah,
Okay.
just
Okay, Jane,
discomfort.
can you please right. Jane, can you please tell me, have you experienced any difficulty with your vision or eye movements or
No,
any difficulty
doctor.
with nothing like that?
No,
Okay. Have you experienced any change in your shape of your hands, your feet, anything like that?
no, doctor.
Okay. Yeah. And you had told me that you have observed, your voice has changed recently, right?
Yes, yes.
Okay. And how has been your appetite recently?
I don't think so. I think I've lost my appetite. I don't eat well now
Okay.
anymore.
Okay. And despite that, you had lost 4 pounds of weight as well.
Yes.
You told me that. Okay. Have you feeling, how's your mood nowadays? Are you feeling agitated, depressed or something like that?
Good.
Yes, I feel agitated quite often.
Oh, right. I'm really sorry to hear that out. Okay. So have you been experiencing any joint pain, any muscle pain, any shortness of breath, any chest pain, anything?
No, no, doctor.
Okay. Okay, right. Is there anyone else in your family who has been experiencing the same or who has experienced the same?
Not that I know of.
All right. Are you taking any medications currently?
No, no, doctor.
All right. Any surgeries in the past?
No, I've never been to hospital for any
Mhm.
reason.
Okay. So, are you allergic to any medications?
Not that I know of.
Okay. Do you mind if I ask you some few more personal questions?
Not at all, doctor. Go ahead.
Okay. Can you please tell me what do you do for a living?
I'm actually retired. I was once a school teacher.
Okay. So who is with you at your home?
Just me and my husband.
Okay, great. So, do you smoke or do you drink alcohol?
I used to smoke like long back, but no,
Mm-hmm.
I don't
But no,
drink.
no. Okay, okay. All right. So, can you please tell me before you came to us today, you must be having some idea. Do you have any idea what might be causing these all problems?
Well, something similar like this happened to one of I know, and they said it was cancer. So I'm really anxious regarding this.
Oh,
What
okay,
if I've
thank you
got
very much
cancer
for
of the food pipe?
I will come. Your concern is. I appreciate your concern. I will come back to you later on. I have to discuss your case with my consultant. Thank you very much for your time. Okay.
Okay, good.
Thank you, doctor.
Can you present your
Okay.
case now?
I would like to present to complete my history. I would have like to ask ask the patient about the expectations and the concerns she might be having about this condition.
Yes.
And after that, I would like to do the thorough examination. My differential diagnosis is patient is having uh,
Yes, but
CA thyroid.
the history you have
CA
taken, first you have to tell me
yes,
that.
yes, ma'am.
66 years.
So my provisional diagnosis is the carcinoma of the thyroid, but I would also like to rule out other conditions like hyperthyroidism due to any cause like Graves' disease, thyroiditis, hypothyroidism.
Okay.
But before, okay, so this 66-year-old female today comes to me with history of swelling in front of her neck 10 years back,
Yes.
who
Since
which has
yes,
increased.
yes.
Yes, since 10 years back, which has been increased slowly over the time. Patient has also experienced 4 pound loss of 4 pounds of weight in the last 6 weeks. Patient mood is not good. She's feeling irritated most of the times. Patient has lost appetite as well. and the patient is sometimes feeling difficulty in breathing as well. There is no significant past medical history. The family history is negative on any malignancies, any other thyroid conditions as well. There is no significant medical history. So patient's main concern is that she might be suffering from some cancer of the food
So
pipe
how
as
would you
well.
confirm your diagnosis? What investigations would you ask for?
After thorough history and clinical examination, I would like to do the triple assessment in this case. That should be including the examination and the FNAC of the swelling or biopsy of the swelling and the radiology of the swelling, that will be including the ultrasound.
What
This
should
will
be
give
the
us idea.
treatment? Yes.
Yes, ma'am. So after assessment, I would like to discuss this case with the consultant. If it turns out to be the malignancy, so
Yes.
we should go for the MDT approach, that will be including the endocrinologist, the surgeon, the specialist nurse, the anesthetist, pathologist, and the surgical oncologist as well. And we can go for either hemithyroidectomy or total thyroidectomy, depending upon the histology we get from the biopsy.
Okay, can you name some complications that can result as a procedure of surgery or complications as a result of surgery?
Yes, ma'am. There will be complications like early complications and late complications.
Very good.
Early complications can be due to anesthesia in itself or due to surgery. That will be including the bleeding.
Yes.
That will be including the iatrogenic injury to the surrounding structures,
Yes.
iatrogenic injury to the parathyroid glands as well. In the post-op period, patient can have hematoma formation, wound infection. Hematoma can give rise to breathlessness or airway obstruction, hypocalcemia, and injury to the parathyroid gland, that can lead to hypocalcemia. So these
Very
can be the
good. Okay.
few complications. Tracheal stenosis, if that would be a late complication.
All right. Good. Thank you. Yes.
Thank
Just
you very
few
much.
seconds you took extra, and then that made you puzzled.
Yes,
I don't know. I felt that
switched.
way. Yes. The moment you left the patient and come to examiner to present history, you, instead of presenting your case, you started telling me about the provisional diagnosis.
Management.
And yes, and
Very
those were the questions I was supposed to ask you in the second half of 1 minute. In the first half, in the first 30 seconds, you had to tell whatever you have been discussing with the
String.
yeah.
Right,
So
ma'am.
I missed. Kindly tell me, did you confirm the symptoms, like confirm the obstruction or compression symptoms, like to
Yes, ma'am.
what extent?
Yes, ma'am.
Yeah, I think you
I
did.
asked patient has she been experienced any difficulty with swallowing or difficulty breathing.
Yeah.
So compressive symptoms I ruled out.
Yeah.
And malignancy also I rule out, because patient was giving me more of symptoms of malignancy.
Yeah.
She was saying like I lost some weight, appetite is not good.
Yeah.
If there have been thyrotoxic symptoms, the appetite is very, appetite is much more than they expected, and the patient
Yeah.
loses weight. But here patient has lost appetite and she's lost some weight as well, and there were some compressive symptoms as well, so I thought it would be
It was good.
malignancy.
You did rule out the mood changes, but maybe menstrual history you forgot to take. If patient is still menstruating or
Yes,
not,
female.
considering it,
Yes,
it was a female patient.
female. Yes,
So yes,
that should I have.
that could have you asked. Otherwise, I think it was good. You told me
Yes,
management doesn't matter in what order you told me. Yes, it does in the exam. But
yes.
then, okay, we have one more day to practice. All right, good.
Right, ma'am.
Yeah.
Thank you, ma'am.
Anyone else want to give feedback? Maybe Dr. Ulfat?
Dr. Ishfaq, you did well,
Yes.
alhamdulillah. Just
Thank you.
yes, ma'am is right. Menstrual history is important for this, and other thing is that at the end, just do the ice. Don't leave the ice. The ice is one of the performer of the
Important.
history
Yeah, I
taking.
told you before as
So
well.
That's right, ma'am.
when you do
I
when
started
you
with the
see that
ice because
Yeah,
yes. Please proceed.
yes.
so ice is important actually. I mean, keep in your mind that you'll have to do ice, and then look at your examiner. But get
Right,
done with
Dr.
No,
the
but
ice.
Ulfat.
if
That is
time
important.
ends, then he
You said
managed
it.
it. He told me that he
Yes,
will complete it with that. So it was as good as
Yeah.
being done. But then,
completing.
yes, if
Yes,
time expires, time bell goes, leave everything,
better
turn
is
to consultant, and try not to be confused or puzzled. Don't control your nerves.
Yeah, I think today at the end you just you were going in a fast pace and then the peak just fell.
Yeah,
So I was
all
like,
of a sudden.
I wanted to type and say that ask me faster, because if you don't ask me, I won't be able to answer you.
Yeah.
So yeah.
Okay. Right. And Dr. Ulfat, you and one advice
She
from
talks
me.
long?
Yeah, the first history
Yes.
explanation, my one was too much. Yes,
Yes,
I
because
got that. I was
There
in
you lost few seconds.
examinations,
Yes.
yes, ma'am. Because in examination scenarios, the actors have been told or patients have been told to give the information whatever candidate asks for you,
Yeah.
not to tell them everything.
No, but
And
sometimes
yeah.
they talk a lot. Unnecessary information they give you. Yes, Dr.
I'm an
Abhishek, you want to?
unnecessary information I gave you today.
no.
Actually, I'm
She told me everything is positive,
No,
whatever
no, you were
it was
not
given the
giving
stamp.
unnecessary, but sometimes, like when you're role playing, then one sentence may take a little longer
A
because
little longer.
yeah.
Yes.
So that's where Dr. Ishfaq has lost few
I
seconds.
lost the time.
Yeah.
Yes.
So
Yes, I
Dr.
felt
Yes,
that
ma'am.
too. I felt
Yeah,
the start
yeah.
was off. Yeah.
So, but that's all right. We understand. So
But
it's
he
not a
It's
did
all
big
right.
good.
deal. He
Ma'am, he
did
did
good.
good.
Yes.
Alhamdulillah. Yes.
Yes,
Thank you.
except for the practice
points I
that
would
whatever happens, he has to control his nerves. He's not going to
Right,
become
ma'am.
nervous all of a sudden. So that practice he
No,
has.
ma'am. I wasn't nurse. I don't know.
Bell
Okay,
went.
ma'am. I should be okay.
You
Bell
were
went.
conscious about the time. So honestly,
Yes,
what
ma'am.
I felt, you were conscious about
Yes,
the
ma'am.
time. The moment bell went,
That's
you
right.
become puzzled all of a sudden. Oh, time is up,
Yes.
and I had to ask this. So
I had to
that's
ask.
yeah.
Yes.
Dr. Abhishek has
Right, ma'am.
a question. Yes,
Raised
please.
his hand.
yeah. The ma'am. Hello.
Yes, hello.
Okay, ma'am. The first thing is like, okay, Dr. Rufa, please don't mind, but you have sent ma'am a stem and you uttered all the things. I think, okay, the most important thing you are facing, the patient is facing, they may utter the first thing, the important thing first. So on the go, if you see, tell all the points, so like we have to then like cut short the things, like we cannot repeat the
No, no.
same question.
Feedback is for
Yeah.
Dr. Ishfaq, candidate, not
No,
for
no, no,
the
no,
simulator.
ma'am. I
Yes,
have written it. That's why I am just making
yes,
it
yes,
clear. Just
yes,
don't
yes.
mind, actually.
No,
Yeah,
no,
ma'am.
she
I'm
won't
really
mind,
sorry
but
for
she
that.
helped us. Yes.
No, Abhishek, it's fine.
Yeah,
Dr.
yeah,
Abhishek, it's totally
yeah,
fine.
yeah.
I got it.
And another thing
It's
is like whenever in a real exam scenario, whenever is like the bell rang, like okay, you have completed this 6 minutes, so you
Yeah.
will never get any time to talk to the patient. Trust me. So you have to face to the examiner then,
Right
because
away.
if you
Yes.
don't face to the examiner, that will be something like offensive. Okay, the examiner has told you like to face towards him, and you are still talking to the patient. That should not be accepted from my point of view, I think, ma'am. So whenever
Right.
It
just
will
bell
cost
rang,
him
we
his
have
mark. Yes.
yes, yeah, ma'am. We have to just thank the patient, then we can utter that what Dr. Ishwak did. We can do that. Yeah.
Yeah, he did that. Yes. And that was correct. It was as good as being done because he said he
Yes,
would
ma'am.
complete
Mentioning
his
it.
examination, his history taking with. Yes, I see,
Yes,
completed
ma'am.
it. So that was as good as being done. But then he should have, instead of telling me his differential diagnosis, should have said, today
I should have
the
summary.
history. Yeah,
Yeah, like I don't
summary.
know, brother, what happened. Like you forgot to
He
say
was conscious
something.
about the time. It was so
Yeah.
obvious that
I
I
don't know
felt it.
what is happening. Yes, ma'am.
That's
No,
what I felt.
everything
I
is
don't know.
Obviously,
fine.
I shouldn't have. af- After 1 year of practice, I shouldn't have
No,
done
no,
this.
that's all right. It's natural. But we'll practice
Yes,
so
ma'am.
that we won't face
Yeah,
this in examination. So
that's it.
thank you, everyone. Thank you so much.
Thank you, ma'am. Thank you, Dr.
Thank you,
Fadak.
ma'am.
Thank you.
Thank you. All right. Here is your question. Timer has been started.
Is this for me or for Dr. Farah?
She asked another history taking. I
This
think
is
she did.
also. Oh, okay, ma'am. Okay, I got confused. Okay.
Yes, she asked for history taking. It's for you, Dr. Abhishek.
No problem.
Yes, please.
Yeah,
If you
yeah.
have
Okay,
read
ma'am.
and understood, kindly begin your examination.
Okay, I'll enter the examination hall. I'll wash my hand. I'll greet the patient, and I'll say like I'll give my identity by saying my name and my position. After that, I'll just check patient's identity by asking his
Not take,
name and
confirm.
age.
Yes.
Yeah, confirm. Yes, I'll confirm patient's identity by asking his name and age.
Yes.
After doing that, I'll give a brief description of the things I am going to do for him. Like I am going to examine his
Description of examination. Yes.
examination. Yes, going to
Yes.
examine his legs, and also that may includes also looking at hands and feeling it,
Yes.
and seeing him walking.
Yes.
So is this okay for him or not? After
Yes.
doing that, I'll just ask the patient if he is any pain or not. If he is in,
You'll explain the
he's in.
exposure as well. How much patient
Yes,
has
ma'am.
to expose.
Yeah,
How much?
yeah. I was going to do after just asking about
Okay.
pain.
Okay.
So after that, I'll just ask the patient that he should be without any trouser, just only on shorts for
Yes.
this station for the examination purpose. And I'll ask the patient then if he is feeling any pain right at this moment. So if he's in severe pain, I'm going to offer the patient some analgesics. Then I'd like to ask the patient to walk a little few distance for me. So if the patient can't do that, I will not request the patient to do that. And I'll also check if the patient can walk on his toe and also on his heels or not.
Yes.
After doing that, I'll ask the patient to lie on the couch, and after that, I'll just do some inspection for this patient.
Yes. Yes.
I'll start with the hand actually. I'll see if there is any nail fold intact, if there is any evidence of nicotine staining, and also if there is any evidence of ulcer, skin changes over the hand or not, any venous guttering, any loss of hair. And after doing that, I'll check the capillary fill time of the hand, and then I'll
Yes.
check the pulse, radial pulse of the both hand, and I'll check the things on both sides. After doing this, I'd like to go for the lower limb, the local examination. I'd like to first
Yes.
inspect if there is below the groin. I'd like to inspect the whole legs, also the knees, behind the knees, and also the ankle, and also the wave spaces, also the heel and pressure areas, are all the bony landmarks of the lower legs of the both leg, ma'am. After doing that, I would like to go for the like feeling. Then I would like to go for the temperature on the of the both side by with the dorsum of my hand, like checking the temperature, like from the knee I will go towards distally. After checking
Yes.
the temperature, I'll go for the tenderness. Before that, I'll ask the patient if he feels any pain, just to let me know. I'll just stop it there. I'll check all the bony marks area, like from the chin of the tibia, lateral side of the head of the fibula, and also I'll go over the medial malleolus, over the lateral malleolus. I'll also check over the metatarsal joint, metatarsal bones, and also squeeze the metatarsophalangeal joint if there is any evidence of inflammatory arthropathy over there or not. During this time, I'll look at the patient's face. Actually, so I want to see his expression. After checking the tenderness, I'd like to go for the pulse actually. And for the pulse, first I'd like to check the femoral pulse, like in the median, like 2 to 3 centimeter below the median inguinal point. After doing bilaterally, after that, I'll have to go for the popliteal pulse. I'll have to
Yes.
flex the knee at least to 15 to 30 degree. I'd like to check with both of my hand the popliteal pulse, of if there is any evidence of popliteal masses over there bilaterally. After that, I'd like to go for arteria dorsalis pedis pulse, against the navicular bone in the proximal part of the first OFA space between the extensor hallucis longus and brevis. Then bilateral.
Where would you palpate the pulse for posterior tibial artery?
Yes, ma'am. I'm going to say that. Like I can palpate the pulse for posterior tibial artery halfway between the posterior border of the medial malleolus and the tender heel of the ankle or tender Achilles, insertion of the tender Achilles. I can check for that. If I don't find any pulse, I'd like to use Doppler for the finding the pulse. After doing
Would
that,
you, yes,
yes, ma'am. After
would you
checking the
confirm
pulse, I'd like.
pulse of any other parts?
Yes, ma'am. Femoral, popliteal, arteria dorsalis pedis, and also
radial
the
and
posterior tibial. Yes,
radiofemoral.
and
Yes,
then I'd like to go
delay.
for the radio, if there is any radiofemoral delay
Yes.
over there or not. Yes,
Yes.
ma'am. Radiofemoral delay over there.
Yes.
And after that, I'd like to check the capillary refill time of the both of the legs, and
How much is
then
the
doing
normal capillary refill time?
like within 2 to 3 seconds, there will be refill. There will
Within
be
2, yes.
return of the
Or less
normal
than 2
color.
seconds. Yes.
Less
Good.
than 2 seconds. Yes, ma'am.
Okay.
After
Good.
checking the capillary refill time and pulse, I will go for if there is any evidence of I'll auscultate if there is any evidence of bruit over there. Then for auscultation, I'd like to go for first the iliac artery, above the midinguinal point of the both side with the bell of the stethoscope. Then I'll go for the femoral artery, like at the point of the adductor canal bilaterally with the bell of the stethoscope. I'll go for the popliteal bruit also in the popliteal fossa. After doing the auscultation, then I'll go for if there is any time, I'll go for the ankle brachial pressure index. I'll check that sphygmomanometer. I'll check the both pulses of the both sided upper limb, and whichever is higher, I'll take that higher systolic pulse. I'll take that. Yes. After doing that, I'll thank the patient. I check in the ABPI. I'll thank the patient. I'll wash my hand. I'd like to summarize my case.
Yes.
So to complete my examination, I would like to do the full neurological examination of
Good.
both lower limb and the upper limb, and I would
Yes.
also like to do cardiovascular system examination, abdominal
Yes.
examination to see any evidence of abdominal aortic aneurysm or abdominal aortic bruit over there, ma'am.
Good. So
Yes. So
if you
today
can
I have
summarize,
examined
yes.
a 72 years old man who came with worsening sensation of pain in the both legs.
Good.
And yes, on examination, on inspection of the hand, there was some evidence. There may be some evidence of nicotine staining or tendon xanthomata, or also a tar staining over there, and nail fall infarct over there. There was normal radial pulse bilaterally. There was no radial delay, normal capillary refill time. On inspecting the lower limb, there was no evidence of venous gut. There may be signs of venous guttering, chronic venous insufficiency like lipodermatosclerosis or eczematous changes. There was no evidence of ulcer over there, and there may be loss of some decreased temperature due to decreased circulation over one lower limb, and also there are some tenderness over the ankle or over the calf muscle. There may be. So after doing the timber, there was normal capillary refill time.
Yes.
So according then went for the pulses, but I felt the femoral pulse and popliteal pulse. There may be decreased pulse felt over by the head, like in ADP or posterior tibial pulse. Then I used the Doppler that was audible. There was no audible bruit over there, and the ankle brachial pressure index that may be below below 0.5 or 0.3 any other limb due to this lower limb
So what was
claudication.
your differential diagnosis?
Yes, for this patient, my most probable differential diagnosis would be it may be chronic lower limb, a case of chronic lower limb ischemia, ma'am.
Okay, so can you?
Yes, and differential maybe,
yes.
ma'am, it may be neurological pain. It may be a case of spinal canal stenosis.
Yes,
It may be
yes.
a case of common peroneal or sciatic nerve root impingement.
Can
It
you
may be a
please
case
tell
of
me
polar
what is?
yes,
Yes,
ma'am.
please. Can you please tell me what is the importance of doing ABPI? Ankle
Yes, ma'am.
systolic
ABPI.
pressure. Yes.
Yes, ABPI actually indicates if there is any the degree of degree of ischemia actually. So in this case, the
Degree or
systolic pressure
severity. Yes.
severity of the ischemia. So in this case, the systolic pressure of the ADP and posterior tibial artery is taken, whichever is higher on either limb that is taken, and it is divided by the highest systolic pressure of any of the upper limb. Like we
Very
can get
good.
120
Okay,
one
this was
side
my
and
next question.
yes,
Okay,
yes,
how
ma'am.
this
So
patient
yeah.
should be managed?
So I'd like
How
to
would
manage
you?
this
Yes.
patient.
Yes.
Yes, ma'am. I'd like to take adequate history from this patient, and then
Yes.
I'd like to go for do some investigation for this patient, some routine blood investigation, full blood count, yes, sir, CRP level, blood glucose level, blood lipid profile, blood lipid profile. And after doing that, I can also do the liver function test, urea electrolytes, and then I would like to go for a specific investigation. I can do the arterial
Okay.
duplex or
Bell
Doppler
has gone,
ultrasound.
but one last
Yes,
question
ma'am.
I want you to answer,
Yes,
please.
ma'am. Sure,
How
sure.
would you define critical limb ischemia?
Okay, critical rehab ischemia actually includes three factors, like if there is any evidence of tissue loss in the form of ulceration or gangrene, if there is any form of rest pain, and if there is ankle brachial pressure index less than 0.4.
Very good. Excellent. Good. Since time has ended, so I had to interrupt you. Otherwise, you were answering it very well. And that's the point. That's when examiner interrupts you, when they realize you know the thing. So what's the point making you say it all? So good. Very good.
Thank you, ma'am.
Good.
Sorry, ma'am, my voice is little.
And here is your question. What? It's not coming. Yes. Keep reading. I'm not giving you 9 minutes. 1 minute. And here. Yes.
Go ahead.
Good. Yes. Now you can read.
Go ahead.
That's it. So you can read. Or I can go back and make you read the back one.
Yeah, go back. Okay. So should we start?
5 seconds, please. Yes. So if you have read and understood, kindly begin your station.
I'll enter the room, tell my name. I'm Dr. Nadeem, the surgical candidate. I'm calling, ringing the bell. Hello, may I please call to the emergency consultant, Dr. Abhishek. Hello.
Yes,
Please
I'm
may I
talking.
confirm? I'm Dr.
Yes.
Nadeem.
Yeah.
Yes, thank you. So can I please take few moments of your time, sir? Can I please discuss a patient? Okay,
yeah,
so
sure.
there is a
Summarize your case
22-year.
for me.
Thank you so much. So there is a 20-year-old gentleman who had a RTA and has been injured severely. Can I please explain more?
Yeah, sure.
I
Summarize
need.
his case, please.
Oh,
Yeah.
okay, that's great. So, sir, he was basically hit and run by a vehicle, and he was brought to emergency, and surgical call was given. So, on initial examination, his GCS was 15/15, and his initial tests were done, and X-rays showed tibiofibular open fractures. Ultrasound abdomen showed fluid in the paracolic gutter, and nurses also noted pulseless extremity in the left side.
Okay. So what is the most urgent thing for this patient?
So previous slide, please.
Yes.
So uh, uh, there is also some abrasion on the left side, but keeping all these things in view, there is an open fracture for which I have to call the orthopedic surgeons to fix it. But apart from them, the most urgent is pulseless cold limb on the left side, for which I will need a vascular surgeon immediately. And I'll also need to keep you in loop, sir. Is that right, sir?
Okay. So is the patient wearing a cervical collar?
I'll have to confirm it because at the moment I don't have read it. I don't know it.
No problem. So do you think the patient is dehydrated?
For that, I'll need to see how much fluid has been given, and I'll need to re-see the fresh vitals.
Okay. So what is your plans of action? Can you please tell me?
So, sir, I have to optimize the patient and send all his labs again, if not done, any missing labs like CBC, serum electrolyte, RFTs, and this ABGs, cross-matching blood grouping, arrangement of blood, IV fluids, crystallites, and airway breathing circulation, triple immobilization by hardboard, cervical collar, and strapping around the waist, and also splinting the fractured area, and also cleaning the any dirty wound areas, and looking for vitals, starting antibiotics, calling the OT team, manager and consultants, anesthesia, and also my consultant, trauma consultant, orthopedic consultant, and on the top of it, the vascular surgeon, which should come first.
Okay. Any other
I'll
drug
be
you
chairing
want to
the next.
give?
So I'll also need to give painkillers
prophylactic
to
drug?
control the pain.
Sorry, any other
And also
prophylactic
the
drug?
tetanus. Yes,
Okay.
I'll also check for the tetanus status. So if the patient has not taken any tetanus booster in last 10 years, then I'll need that. And if no immunization, then I'll also need immunoglobulins apart from the immunization.
So can you please tell me, like, what are the investigation you have already done and you want to do further?
So the one which I have already done, if they include
tell
the
me
HB
what you want to
loss
do
and
actually. Yeah.
so I want to do, I want to see HB, the RFTs, serum electrolytes, ABGs, the CRP, also CT scan abdomen, pelvis if needed, if it is warranted, and X-ray of the extremities has been also already been done.
Okay.
And
for the
cross-matching
pulseless
blood.
foot?
So for pulseless foot, I have to do the this CT angiogram or what you say, embolectomy,
Okay.
or what you say, angiography.
Yes.
And exploration
So
by
what will you
vascular surgeon.
do? What will you do before sending the patient to the theater actually?
So I have to do what is said that you mentioned it in ABPI,
Like the
Doppler.
preoperative preparation.
Yes. So for preparation, I have to optimize the patient. For preparation before OT, I have to optimize the patient, IV fluid infusions, antibiotics, putting the patient on oxygen if needed, and airway breathing, circulation management, and extremities, debility check. And
okay. So how do you fix his fracture immediate as an immediate basis, and why?
Splinting. So
okay,
I have to
so why
splint it so as to
you
reduce
like, yeah, what is the benefits of
splinting plus
splinting
external fixation to buy time for definite fixation later on.
Okay, so any other benefits of external fixation?
So it will it is less time consuming and bring the like reduces the further debility of bone or complexity of the fracture, and later on helps in further plating or scraping of the bones.
Okay, so the people I may need to call either preoperative or intraoperatively, what are the departments you want to involve?
So vascular surgeon on top, then general surgeon, trauma surgeon, orthopedic surgeon, this whole, and plastic surgeon, if needed.
So why plastic surgeon?
If there is a lot of skin loss,
yes,
and anesthetic. If the skin loss is more, in case, then we will need plastic surgeon.
And why general
but
surgeon?
Later on, not now. Which surgeon?
Why general surgeon?
General surgeon, just to see if there is any intra-abdominal, in such an injury, or pelvic organs injury. So if the case arises, then I'll need them. In case of peritonism or intraperitoneal bleed or fluid collection.
So what would be the management for free fluid in the abdomen?
So we will first we will examine the patient serially. If the abdomen becomes tense, peritonism develops, fever develops, there is shock, then after optimizing the patient, antibiotics, NG tube, passing Foley's catheter, looking for vitals, we'll go for laparotomy if there is gas under the diaphragm or any collection on the X-rays or any free fluids in the pericardic gutters.
Do you need me to come now?
PAS scan.
Do you need me to come now?
Sir, I'll keep you in loop. Let me, yes, you can please assess the patient the earliest possible, and then also advise me further to follow the patient.
So then why are you calling me right now?
Say you may because
it's a question.
Patient may need,
it's a question.
It's a question. That's what I'm saying.
Okay.
You have to say yes.
So I have to involve you in this care and to let you know that you will be needed.
Why? patient might need surgery later overnight. Yes.
Yeah, in
So
this
it's
surgery,
a
in this
question.
procedure.
No need to laugh. This can be asked.
Yes.
Yes.
Okay, so do what have you have told me actually do accordingly, and let me know if any critical situation arises and if I need it. Okay,
So I'll
Yes.
if
let
I
you
am
know.
needed.
Yes.
If any suggestions, you can please, sir, tell me so that I
No.
can
What
tell
have
you
you
again.
told me? You just do accordingly. Okay.
Yes. Good.
Thank you so much, my consultant.
Okay.
Thank you. All
And
right. This one I didn't enjoy. Dr. Nadim, you have to go
I
back
do.
and read once more, right? So that
Yeah.
once you are
Okay.
answering questions, you have plenty of words to answer. And maybe to keep you in the loop, it's you can say that to a friend, but to a consultant, maybe not a decent word.
On board.
You
Okay.
updated, yes, to keep you informed, like
Can I
more
say something, ma'am?
respectful words. Sorry.
Can I say something after you?
Yes. Yes, please go ahead.
Okay, Dr. Nadim. Actually, brother, I'm just suggesting like you have like started about your starting. So for this communication and over phone call thing, we follow the mnemonic like S bar. The situation, background,
Yes, yes.
assessment, and the recommendation. So you set a recommendation at the end. So at first,
Yes.
whenever you are calling, just give a brief thing, like brief description. Okay, I have having a patient. Yeah. So this critical situation arises. Can I please talk to? Can I please confirm? So after giving a hint, then you just summarize, and whatever is there, you just divide that about the like background, assessment, and recommendation. These 3 points you will do in summary, and after that you will be asked about the relevant questions. So it will be easy if you just divide this in that way. Okay.
I totally
And
agree
for,
to you. If you write
yeah,
them
yeah.
like in Vitas examination, no, I'm working on. That's
Yeah.
fine.
And
Yes,
Good.
actually,
Good.
totally
yeah,
agree.
what I follow,
Please
brother,
practice.
actually, yeah,
Hmm.
in case of this background assessment and the recommendation, at first I tell the chief complaints, whatever
Mhm.
we have, like a patient came with road traffic accident, and I
Yes.
on arrival I found this. Okay, then I go for the on examination thing. Then I go for the investigation that are
Labs.
available for me. Yeah, these three things I
Yes.
keep chronologically, and after that why I am calling to him, I just mention it like I am just asking some advice. So I am just planning to refer the patient under him for some definitive care. So this thing is the recommendation. So after doing this summary, then you will ask about the relevant. You will answer about the relevant questions. I think that would be easier if you go through like.
Yeah, thanks a lot for all the feedback. It all needs, practice.
Yeah. Dr. Ishfaq has a feedback. Yes. Oh,
Yeah,
yes,
yes, ma'am.
please.
Dr. Nadim, you did really good, but I must be honest with my feedback. You talk few things out of your gut, which
Yes.
shouldn't have been, because
Yes.
you need to rephrase your words. Because
Yes.
in exam, they don't care how much you know, how much you have done in your past, whatever. We have to follow a protocol, like Dr. Abhishek told you. We have to follow the S bar. After introduction, you have to follow the S bar: situation, assessment, background, and recommendations. And rephrase your words,
Hmm.
please. Like ma'am said, you can't say a consultant like, I will took you in the loop, and
Yes,
most probably
on board.
examiner will
Hmm.
fail you on that thing.
Hmm.
So
Totally agreed.
this is the honest feedback, and we have still time to improve ourselves,
Yes.
and things should be like that. And better is to go through the notes, otherwise you haven't done
Yes.
anything wrong.
No.
But
But there
how
was
to
less
present
when
and
yes.
little bit. Yes,
When
right,
doctor
ma'am.
No, no, thank
was
you so much.
asked why you want to involve general surgeon, then he only talked about one thing. So there could be wound. Patient has wounds as well, and they general
Mm-hmm.
surgeons who do the debridements. Okay, and then there could be even compartment syndrome of abdominal.
Oh,
Yes.
yes.
So
Yes, yes.
just mentioning one that there is to rule out
Mm-hmm.
intra-abdominal injury is not enough. If he would go back and read the notes, he'll come up with more things to talk about. So things are there already, he knows them, but he has to go back and read. Yes, I agree everything you said, Dr. Ishfaq. Then he will have more vocabulary.
Thank you, Ashfaq. Thank you, Abhishek.
And
Thank you,
even
madam.
when you were telling about the pulseless leg, then you were not even coming out with the right investigation that you have to do. So time is
Yeah, Doppler.
clicking, time is going on. So you have to say, okay, you'll do bedside Doppler. So it's not just simple Doppler. First, you'll rule out with the bedside Doppler, right? And then, if it's required, it's necessary, then you'll do the CT and you'll do the lower leg angiogram. So it's not just foot, it's the whole leg which is pulseless. So you'll do the lower leg angiogram. So you have to say
Lower
see
limb angiogram.
whole,
Okay.
yes, yes. So
Yeah.
that would be good. Yeah.
Thank you so much. Now
Yeah,
I will
still
not
a lot
forget
of
about
time,
this.
but you're getting there. We are giving you feedback so that you know
Yeah.
what to improve. Good, very good.
Thank you.
Thank
Thank
you.
you.
Question. Not yes. Not too much, but still, you know what you have to do.
Yes, ma'am.
Right. If you have read and understood, kindly begin your procedural skills.
So I'll enter the examination hall. I'll wash my hands.
Yes.
Hello, good morning. I'm Dr. Ulfa Jahan. I'm one of the examination candidates. Can I please confirm your name and age?
Yes, you know, these days there are no
All right.
patients, so yes.
Okay, so
So you
after
have
I've
to
confirmed
narrate. Yes.
after I've confirmed the patient's identity, correct identity, I will
Yes.
now explain the patient that I will be draining the lump from her, from the site, and then and that will be done under local anesthesia by first numbing the area. I will also explain to the patient that this I'm going to do. If the patient might feel slight pain, but while I'm numbing the area, I'm going to now ask to check the patient's file to see if the patient has consented for this procedure.
Good.
Then I'm going to check whether the patient has some comorbidities like hypertension, diabetes, or any bronchial asthma. I'm going to ask whether the patient is taking any regular medications, including any blood thinners like aspirin, clopidogrel, and also if the patient has any allergy to latex or any particular medications. After that, I'll proceed for the WHO checklist and see whether this is the correct patient, correct site, and also then after that, I'm going to wash my hands. I'm going to wear my cap, my mask, and put on my gown, and I'm going to set my equipments, including and I'm going to take a number 11 blade, a hemostat, and also a swab stick. And then I'm going to prepare the skin. I'm going to wash the skin with alcohol swabs or chlorhexidine, and then I'm going to drape and sterilize the air and drape the wound. After that, I'm going to ask the patient. I'm going to say the patient that now I'm going to inject I'm going to inject I'm going to insert the local area to numb the area so that you don't feel pain. And then I'm going to take the local anesthetic, preferably 2% xylocaine, and then with a baby needle, and I'm going to inject the area and anesthetize it and wait for 3 to 5 minutes. And then I'm going to check with a tooth forceps to see that it has been successfully anesthetized. Then I'm going to take the number 11 blade and at the tip and give a linear small incision at the most branching point of the abscess. And And then as soon as I do so, there's going to be pus that will be expressed out. I'm going to swipe it with the gauze piece, and then again I'm going to encourage expressing from either side. And after that, I'm going to take a swab stick, and I'm going to take a sample for microscopic culture and sensitivity. After that, I'm going to take the blade again and elongate the incision and create an elliptical incision so that the margins don't oppose. And then I'm going to express express all the pus that is there, and then I'm going to insert the hemostat and break down any hemostat and widen the opening of the wound, and insert my finger and break down any loculi, creating a single cavity. After that, I'm going to irrigate the cavity with normal saline, with the syringe and normal saline, and or if I see that it is and if there is any necrotic tissues, skin tags, I'm going to debride them. Then I'm going to, if required, I might even do it with 3% hydrogen peroxide, depending upon the state of the wound. After that, I'm going to wash the wound with a normal saline irrigation, and then I'm going to place in. I'm going to now I'm going to keep the wound open, and I'm going to give a light packing with normal saline soaked wick, keeping the tail out, and then I'm going to apply a sterile dressing. After that, I'm going to discard all the instruments. The shops will be discarded in the shops bin, and then I'm going to document the whole case, including the date, time, the site of the abscess drainage, and also the local anesthetic used, and the arbitrary amount of pus that has been sent, and also regarding that the sample and the swab sample has been sent for microscopy and culture sensitivity. After that, I'm going to look at the patient and give them a post-operative plan. I'm going to advise them that since you're going to feel a bit of pain, so I'm going to give you some analgesic. I'm going to give you antibiotics, which you must take regularly, and also you have to come for regular dressing. But you have to come 24 hours later to remove the pack that I have put. And after that, we'll see your wound, and then prescribe and advise regarding regular dressing. And also, I'm going to tell them to look out for some warning signs, like if the patient develops fever, if there is any, if the wound the dressing gets soaked, or if she sees blood in the dressing, then she must immediately come back to the doctor. And then I'm going to end my procedure. Thank you so much for your cooperation.
Okay.
And wash my hands.
Yes. Right. Did you tell patient you still had 50 seconds left? Did you tell the patient how often they will be needing dressing?
Ma'am, I said regular dressing, but it will depend upon the after 24 hours when we see the this thing. Yes, I mentioned the dose of LA will be dose. No, I did not mention the dose. Do I have to mention the dose here, ma'am? I just said it is 2% xylitol that I'll be using, but it will be it will be 3 milligram per kg body weight of the patient.
Yes, according to the body weight, and they can even ask you to calculate the dose of local anesthesia. So maybe if you consider the patient to be 70 kg of weight,
then 3 into 70, 210 milligram.
All right. Okay.
Weight of the patient. Okay.
Yes. What advice would you give? Because still I have 2 minutes to ask you questions. What advice would you give patient that what precautions they have to take before changing their dressing?
So the precaution should be that first of all, they have to check for any warning signs, and then return back 24 hours later, after which the normal saline soaked wick will be removed, but first it will be made
removed and
it will be moistened.
Replaced by what?
By an alginate dressing.
Very good. Okay.
Yes. And
what is the advantage of using alginate dressing?
It will heal. It will alginate dressing. It will heal. It will potentiate tissue healing.
Okay. And when removing the dressing, what measures you should keep in your mind you have to take?
While removing the dressing, I have to moisten the wick before, or else I might even disturb the granulation tissue formation.
Yes, very good. Okay. What else is important when you're doing alginate dressing? So
I have to ensure that the size of the alginate dressing should correspond to the size of the wounds, because there is chances that excess of it, if lies on the skin, may cause maceration of the skin.
Normal tissue, yes, very good. Okay. Right. Would you give or would you not give a dose of antibiotic to the patient?
Yes, ma'am. I would give a dose of antibiotic now since I've already drained the abscess.
Okay.
Cavity.
All right.
An
How
empirical
much?
dose of antibiotic.
Okay. Maybe I think if I'm
But
not
then
wrong, we
later on,
discussed. Yes.
but later on, when the reports of the microscopy and culture sensitivity is available, then accordingly, we can switch the antibiotics, which will be available within 72 hours or so.
Yes.
So, and then we can inform the patient.
Okay. Good. Very good. All right. Well,
Thank you, ma'am.
fine. Yes, thank you. And in these stations, like you were explaining later on, that's how things are happening because they are not having any patients. Before
Okay,
they
ma'am.
used to have, so it will be just like.
So I'll immediately go and tell them that I'll introduce and then I'll take consent like that, right, ma'am?
And identify or confirm the identity of the
Patient's
patient and all that.
identity.
Yes.
Oh, okay, ma'am. Ma'am, another thing, I just wanted to ask: this abscess drainage, it is going to be in the operation theater, right? So in that case, I will do the WHO checklist with the excuse me, with the other members of the theater, right? Or no?
Yes. If you need, you can ask for a helper or assistant, and it would be probably the examiner who would volunteer to be your assistant. Dr. Ishfaq has raised hand. He wants to say something. Yes, please.
No, ma'am. It was from the last,
I'm sorry.
last stem. Yes.
Yes.
Sorry, ma'am.
Yes.
Okay, I
During
just want to
issue
check.
the mod. Yes. Okay. Have I missed any comment? No. Okay.
No,
Good.
ma'am.
Thank you. And here is your question. Yes. If you have read and understood, kindly begin your history taking.
Hello, I'm Dr. Farah. May I please confirm your name and age, please?
My name is Tom, and I'm 43.
Okay, how can I help you, Tom, today?
Doctor, I have got pain in my legs.
Can you please tell me the exact site of your pain? Which leg?
Both legs, and it's in my calves.
Okay. So since when did you notice it?
From last few months.
Okay. Is it increasing?
Yes, I can't walk anymore.
How far can you walk without pain?
From here to the shop outside the coffee shop you have. Is it 50 meters maybe?
Can you? Okay, I see. Does the pain goes anywhere?
No, it just comes in my legs.
Okay. Did it started suddenly or gradually?
So when I start walking, I start feeling this pain in my legs, and then it starts getting worse, and then I can't walk.
Oh, I'm so sorry to hear that. Okay, can you please tell me, do you feel any numbness or weakness of your lower limb?
I do feel numb, but no weakness. But I think it's more because of
Do you
pain.
feel? Okay, I see. Can you tell me that? Do you feel any coldness of your feet?
Yes, all the time. I had cold feet since I was a kid. That's not new.
Okay, so do you have any breach of your skin? Do you notice any breach of your skin in your lower limbs?
No.
Okay, can you tell me please that what affects your pain? Like, does walking, do you feel any pain while resting?
No, with rest it gets better.
Okay, and does in walking uphill or upstairs affects your pain?
I haven't noticed that, but it's really worse in winter.
Okay, I'm sorry to hear that. And can you please tell me that, can you please, does your affect your normal life, this pain?
Yes, I used to walk like maybe walk normally like anyone else. Now I can't walk at all.
I'm so sorry to hear that. Can you please tell me that, can you please rate the pain, like 1 to 10 being the 10 the worst and the 1 is a good one? Can you
9.
please rate your pain?
9.
Okay. Can you please describe the pain? Like, is it cramping or spasmodic? What's the pain feel like?
It's crampy pain.
Okay. Do you have any past medical illness?
No, fit and well.
Do you take any medicine?
No,
Do you have any history of surgery?
no.
Okay, I'd like to ask you some personal question. So, what do you do for a living?
I'm a taxi driver.
Okay, who do you live with?
Family?
I see. Can you please tell me, do you smoke?
Yeah.
For how many days and how many sticks per day?
I use roll-ups. 8 roll-ups per day.
Okay, so do you drink alcohol?
Yeah, but not a lot.
Okay, so what is the most concern of your the symptoms?
Look, doc, I can't walk.
And what's
it's affecting my life. I can't. I'm a taxi driver. I can't. Well, I'm a taxi driver, so yeah.
I'm so sorry. And so what are you expecting from us to do for you?
Well, I'm expecting you to tell me what's going on.
Okay. So do you have any chest pain, any shortness of breathing?
No.
Do you have any problems in your bowel movement or difficulty in urination?
No.
Okay. So is there anything else you want to tell me?
No.
Okay, thank you, doctor. Thank you, Tom. We will see what can I do for you. Thank you for now.
Okay.
You still have 1 minute. Ask more questions. Did you ask pain at night? If patient feels any pain, experiences any pain at night?
I asked pain at rest, not night.
Yes, that you can rule out now. What is the significance of asking pain at night? Does the patient has any history of back pain?
No, I didn't ask that as well.
Yes,
Yes,
you can ask
that's
now.
the question.
1 minute is
Do you
left.
have any
That's
back pain?
No.
Okay. Right. Numbness you asked, right?
Yeah.
Yeah. And
Yes.
severity she asked whether recover. Okay. All right. Very good. You went so quick.
About
3
the skin
seconds.
changes or any
She
ulceration,
asked.
did you ask?
She asked.
Okay,
There
that's
are
good.
exclusively.
That are
Yes.
the main,
Yes.
main things for this
Yes.
station.
So very good. She went really good. Okay. Please present your case now.
Mr. Tom, 43 years of age, presented with the cramping of the both lower limb, which is increasing progressively, and she is chronic smoker,
Yeah.
and the pain is mainly on the calf, and
Yes.
there is no radiation, and there is no ulceration,
Yes.
and the pain is affecting her daily life,
Yes.
and
Yes.
it's on severity it's about 9, and
Yes.
there is no clinical manifestations of neurological symptoms,
Yes.
numbness or weakness, and pain also increases in the winter, cold
Yes.
weather,
Yes.
And she has a cold feet.
He.
So
so what are your provisional diagnosis?
So my provisional diagnosis is claudication, intermittent claudication due to arterial ischemia, chronic arterial ischemia.
Okay. What else are you going to consider?
I'd like to consider spinal stenosis, spinal canal stenosis, and disc prolapse, and spinal claudication.
Okay. How would you? Sciatica. Yes. How would you confirm your diagnosis?
For confirmation of the diagnosis, I like to do some physical examination and neurological examination as well, and cardiovascular examination. Then I like to do some investigations is duplex angiogram of the both lower limb vessels, MR angiogram and CT angiogram. And I like to do some blood tests to see CBC, blood glucose level, and the lipid profiles.
Okay. So what should be the treatment for this patient?
If it's a chronic vascular ischemia, then I like to first optimize his blood glucose level, lipid profiles, and I like to give some her anticoagulants, antilipid, control of the blood glucose, and like to do some invasive procedures if endovascular, either endovascular or surgery.
Okay, just quickly tell me, how would you differentiate between spinal or vascular claudication?
In case of the vascular claudication, in moving the uphill, patient will increase in pain. But in case of the spinal canal stenosis, but spinal claudication, patient will release pain after moving upwards.
Very good. Okay. Any other difference? There's also associated limb numbness in case of spinal claudication.
Yes. Spinal claudication, yes.
And in vascular, what would happen? Exercise will relieve, exercise will bring on, exercise will bring on the pain, and rest will relieve the pain.
The rest will relieve pain, yes.
Yes. Maybe something else we can discuss, like exhibited by walking faster, and the risk factors are associated with atherosclerosis, diabetes, smoking, these sort of. Okay, and rest pain indicates critical limb ischemia. Very good. Okay, you went like bullet. You covered almost everything, and it was good. You saved some time. Yes, empathy. Yes. In the beginning, when you started and you said, "Why have you come?" A patient told you because patient has pain in the legs. Then you could have said, "Oh, I'm really sorry to hear that." Then you could have asked, "How long or when did you notice?" Or all the other questions were absolutely right. But then I felt the need that you need to. In the beginning, you didn't, but later on, you did say, "I'm sorry to hear that," when patient was telling you about the limited movement. But then in the beginning, you have to connect to the patient, and to connect is like show empathy when patient started. So this one thing I have noticed. Other than that, it was excellent. So maybe one point you will lose for not being so empathetic right in the beginning, because you say it's the first impression is the last impression. So the first impression that you'll give, that you're empathetic, you are feeling the pain of your patient, that's when you'll score the more points, because after like 2-3 minutes everyone stops listening so consciously. I don't know, I'm like that, or everyone is like that. So yeah. For examination, yes, it was history taking. For what she had to take exam permission?
No, ma'am. Like today, I have been asked to ask you a few questions regarding. So I will take permission for history also, ma'am. I mentioned that actually.
Yeah. But it's the way how you put questions. The way she put them up, they were very practical. And the only thing she missed when patient said that I'm here for my pain in both legs, then she said, "Oh, I'm really sorry to hear that." Okay, then
Yes.
all right, just this small bit. Otherwise, it depends how you start your history taking, or how you start your conversation. That, yeah, you can ask in different ways, so that's her way. It was very good, it was practical. That's how they are doing it, and it's simplified. Just okay, this is what I can come up with, and very good, excellent, you went ahead with time. Started the timer, and here is the question. Right, if you have read and understood, kindly begin your history taking.
Hello.
Hello.
Hi, my name is Dr. Zara. I'm one of the surgical candidates. Can I confirm your name and date of birth, please?
My name is Max, and I'm 33 years old.
Hi, Max. Nice to meet you.
Hi.
I understand your GP referred you to us for a swelling in your right groin. Is that correct?
Yes, yes.
Tell me more about it. When did you first notice it?
Well, I noticed this about 8 months ago.
And did it happen to develop all of a sudden, or it was like a small lump and then started growing in size?
Well, I actually, it was gradually increasing in size. This was a small lump.
It was a small lump. And is it painful?
Yes, it's painful.
And has it always been painful, or it was not painful to begin with, and now it is more painful?
Well, now it's more painful. Yes.
Okay. Does this pain go anywhere? Does it come to your tummy or towards your back?
No, it's there.
It's just surrounding this lump.
Yeah.
Have you noticed any skin changes?
There is a bit reddish, not much.
And again, this redness is new, or it was always there?
It's for the last 1 week.
Last 1 week. Okay. Any discharge or any punctum you can see?
No, there is no discharge.
Any fevers, rigors, or chills you have experienced?
No fever.
Do you think this swelling is pulsatile, like it moves up and down?
No, it's not.
And do you think you can move it if you want to move it with your fingers? It goes sideways?
No.
No. Okay. Anything which makes it better, like it can decrease in size?
No, nothing.
Okay. And it is always obvious swelling, like when you lie down, do you think the swelling goes back?
No, it's nothing like that.
Okay. And if you try to reduce this on your own, can you do that?
No, it's there. It's not reducing by itself or by myself.
Okay. How are your bowel habits?
It's fine. It's fine.
No constipation, no diarrhea?
No.
Have you been sick?
No.
No. Your appetite is good?
Yes.
Okay. Any other lumps and bumps in the body?
No.
And have you noticed similar swellings in the past?
No.
Okay. Anything which you believe makes this swelling worse? Any particular which makes this pain goes worse?
No, nothing likely.
Okay. Tell me more about yourself. Any other medical problems?
No, actually, I took some injection recently. Recently, I have injection here. After that, I noticed this swelling.
Okay, what sort of injection?
It's like tonic injections, stamina tonics.
I'm sorry to ask you this question, but by any chance, do you inject yourself?
Yes, yes.
And what do you inject?
Sorry?
What do you use to inject?
These were some medicines that my friend gave me, and I injected it.
Okay. But you have never used anything like heroin or something like that, stuff like that?
I don't know about the name, but my friend said it's like mood elevators, so yeah.
Okay. Do you have any allergies?
No.
Okay. And are you on any regular medications?
No.
What do you do for your living?
Actually, nothing more. I'm an instructor, training instructor, gym trainer.
Gym trainer. Okay. And who's at home with you?
I live with my mother.
Okay. And you're otherwise independent in your daily activities?
Yes.
Good. Do you smoke?
Occasionally.
And are you a drinker?
Sometimes.
Okay. Is there anything else which I missed and you want to add on?
Well, yes. You asked about the lump. Sometimes I feel there is a pulse. I missed about it.
Oh, okay. Okay. And you never had this before. This is the first time.
Yes.
And when did the pulse? When did this pulse you notice? Like after how many days of the injection you last used?
I noticed this last 2 weeks.
Last 2 weeks. And when was the last time you injected?
At 8 months ago.
You injected 8 months ago, and the swelling appears 2 weeks ago.
Mm-hmm.
Okay.
No, the swelling is since 8 months.
Okay. What are you expecting from this consultation today?
To get rid of the swelling.
Right. We'll get back to you as soon as we can. Thank you so much for your time.
Thank you.
And we'll let you know, okay?
Thank you.
Hi.
Can you present your case now?
I've been asked to take a history from a 33 years old, otherwise fit and well gym trainer who happened to have injected some tonic in his right groin 8 months ago and noticed a swelling since then. The swelling started to pulsatile 2 weeks ago. He reports no rigors, chills, or feeling generally unwell from the swelling. But the swelling is non-reducible, it's not mobile, but it's expansile and pulsatile. He's not on any medications and he's not allergic to anything. He's otherwise fit and well. He is a non-smoker and an occasional drinker.
So what is your provisional diagnosis?
My provisional diagnosis is either he has a pseudoaneurysm or a hernia.
Okay. So can you tell me what is the component of stamina tonic which patient has been using?
I have no idea.
Does it contain steroids?
Yes.
Okay. Can you tell me what is hernia? How would you define hernia?
Abnormal protrusion of viscous from its surroundings or from its contained surroundings.
Okay, protruding through a defect. Protruding through a defect. Okay. How would you plan to manage this patient?
I will after the history. I will examine this patient, and after the examination, I will start with the baseline investigations, blood tests, including full blood count, UNEs, clotting profile. I will perform an ultrasound scan to look at the contents of this hernia, and after the ultrasound scan, I will book this patient for theaters.
Would you involve someone else as well in the management of this patient?
I would like, after the ultrasound scan, if I'm suspicious about pseudoaneurysm, I would like to have refer this patient to vascular surgeons.
Only? What about urology department?
Oh, he didn't give me the history that he has some urology problems, but yeah, probably.
Yes, okay. What should be the management or the treatment for this patient?
Depending upon the ultrasound scan, if he has a pseudoaneurysm, he will need excision of the pseudoaneurysm. If he has a hernia, he will need a surgery. He did not have any obstructive symptoms, so I believe the hernia can be managed as an elective operation. And he will need.
What is being more painful means to you?
Yeah, okay, fine. Yeah.
Abscess.
Yes, time is gone, but then I'm not happy with the way it went on. Yes, and then since she didn't mention, so you didn't tell me in the management, patient was having, see, it's young male and having history of genitourinary tract infections, which is not the first time, right? So past history. So there was a consultation of GUM clinic as well. And then, yes.
Which clinic?
Sorry?
Which clinic?
GUM clinic, genitourinary.
Okay.
What?
I'm sorry, I'm not really sure if I know the question says that he has past history of genitourinary infections, but if
Yes, this time I adopted from Dr. Wazir's notes. So
I'm saying,
there you can read on page 100, 99 or whatever, yeah, 98, 96, page 96. This is given. So yes, so there you'll find everything.
okay.
Yes, and there it states that patient has past history of this, and this term was even asked in the exam, not recently, but I think in October last year, 2019 or something. Yes. All right, good. So, what else? Yes, in history taking, you could have asked one, you could have added one more question if the patient has history of recent overseas travels. If patient is having, like, once you came to know, okay, patient is having genitourinary tract infection history as well, then you can even ask if patient has one partner or multiple, and if patient has been ever tested for HIV. What more you could have? Yes. These few questions with regard to this history you could have added, and since it was becoming more painful, so signs of obstruction were there, so you could have asked if you ever felt nauseating or you have ever thrown up. So maybe, yeah,
I did ask about fitness.
yeah, so being painful means like signs of obstruction are there, or being, yeah, apparent now. So yeah, anyone else want to add anything? Okay, no, thank you.